uh, Srivastava, who has joined us today as a speaker on the occasion of Mental Health Day, when we'll be talking about mental health of older adults. Dr. Srivastava is professor and head of Department of Geriatric Mental Health at King George's Medical University in Lucknow. He has more than 30 years of experience in the mental health sector. He's worked extensively in the UK, in Singapore, and in India. He's published in numerous international as well as national peer-reviewed journals and has a host of experience. And it's an absolute honor to have him with us today for this interactive session. So we welcome for this session. At the
Thank
beginning,
you for that very glowing introduction. Thank you.
Thank you, sir. I'd just like to mention to everyone who's joining in that this will be an interactive session. So we do encourage you to put any questions that you have to Sir in the chat box. If you would like to ask your question directly, we request that you raise your hand or let us know, and we can unmute your mic and you can put your question directly to Sir. If you could keep it brief, then that would help everyone to get their questions asked and allow Sir to also give his inputs. The session is being recorded and will be shared on our YouTube channels. So in case you have other colleagues, other friends, family members who are not able to join today, please do feel free to share that. So with that, Sir, I just wanted to begin by asking, we talk about geriatric mental health. Is this something that needs a demarcation? I mean, this year's theme was mental health in an unequal world. What are your thoughts on that?
Which language? English, Hindi, both?
आप दोनों mix करके बात कर सकते हैं. I know we have a mixed audience, but I think majority will be able to understand English, Hindi, whatever you're comfortable in, sir.
So yes, geriatric mental health is a subspecialty or a specialty in itself. Mainly because with the advancing age, things are happening inside our bodies, which we see physically. Features change, muscles, they are not as strong as before. The belly tends to protrude a bit, but what we don't see is a similar kind of changes happening in the brain of the person as well. It's a natural aging process. So I will not go in the details of what they are, but then the mind or the brain starts reacting differently to different things. And add to that, that most of the people would have either diabetes or hypertension or both, prostates. So they are on some back problems, knee problems, all those pains and aches. So people are on plenty of medications. So the medications, while they're effective for the problem which they have been prescribed, but they can have their own side effects as well, which may be very subtle. So when we see somebody, we always ask to bring all their medications together. Not just a prescription, because there are 100 brands of the same medication in the market. And it's sometimes difficult to trace which one contains what. So then we make a list. We always check if somebody is seeing their physicians regularly or not for blood pressure or hypertension. It's not uncommon in my practice to say, oh, we consulted somebody 3 years ago for high blood pressure, and since the medication has been going on, the BP is all right. No, it doesn't work like that. It needs to be monitored periodically. Some blood tests, if required, should be done periodically. And one should definitely be in touch with the person, doctor, who prescribed the medication. Because these are chronic illnesses. They don't get cured. They are only controlled by medication. Then we come to the aging process and all the psychological problems which come up with it, which are very different from that of a working adult. For instance, people have worked most of their adult life, say from age 30 to 60, which is generally a retirement age across the country, right? And on the first day of the 61st year, they suddenly find they don't have to get dressed to go to the office. So, what do you do all day? If we are very busy in our working lives, we don't realize it right now, but we are very busy. We wake up in the morning and somewhere in the back of the mind, it starts ticking what are the things that need to be done in the office today. And suddenly there is no office.
We
Then one thing which
sorry,
is
sorry.
very much cited is children leaving home. I mean, previously it was known that 2 or 3 generations were living together under the same roof. But now children have got jobs in another town, city, or maybe country, or sometimes where their parental home is. Like in a place like Delhi, if somebody is living in the parental house in East Delhi and their job is in Gurugram, they'll spend 3 to 4 hours traveling. So it's easier to shift to closer to the job. So then comes, right, we have spent all our adulthood working for the office, looking after children, getting them married, possibly looking after their grandchildren, and suddenly there are 2 people in a 4-bedroom house. So there's plenty of time on hand to think about past life, to think about what things are, how things are right now. So all these problems are very unique to an older person. And that's very important to see or keep in perspective while speaking to somebody. These are the things which we don't see in a working age adult. I hope I've answered your question.
Yes, sir. I mean, I think it's you've really highlighted how important it is to think about some of the transitions that people go through as they age. A very natural part of growing older is to kind of, move on from your work life, maybe move on from these active responsibilities. Um, but are common mental health issues any different in older adults as
Oh,
compared
yes.
to young? Okay.
Oh, yes. I mean, we say that generally it's one of the 3 Ds, the alphabet D, which we see most of it: depression, delirium, and dementia in that order of frequency. Uh, Depression comes from a lot many factors. People may know that there's a biochemical imbalance in the brain in adults. So, but factored in, there is not much to do during the whole day when a person wakes up in the morning. If unfortunately they have caused physical limitations like arthritis of the knee, pain, their mobility is restricted as well. So all those factors compound often precipitate depression, because we all tend to think, so like 10 years ago, we were so active. I would have no hesitation in going to my friend's house and drive for 10 kilometers. But now it's difficult to get in and out of the car without support. So these are the limitations. Some people do well with the limitations, some people don't. And so that's one of the common reasons for people getting depressed: a bit of social isolation, a bit of finding things to fill up the day, how to pass the time in a constructive way. Yeah, but I mean, there's a difference between an older adult and a teenager. A teenager is happy playing an online game all day. An older person is not. They have sometimes difficulty in navigating through WhatsApp video chat. So playing an online gaming is certainly not a thing which can be used to pass the time. Right? So the priorities change, the interests change. Some people pick up a new hobby and they devote there. Recently, I've seen a lady in mid 80s, well educated, and she said, "Doctor, do you think I can do a PhD?" I said, "There's only one way to find out. Go in for it." Because her hobby was reading. And I'll share something, a patient which I saw quite a few years ago, but made a mark on me. Came into our outpatient clinic, and I asked him, "What brings you here, sir?" He says, "My family has sent me saying I need a mental checkup." Okay. Why do you need, your family thinks you need a mental checkup? He said, "I like reading. And a few years ago, I thought if I read something, I tend to go in details of it. So why not do an MA from it?" So he already had 6 MA. He was a full-time practicing lawyer. Yes, and he was doing the 7th in ancient history. Right. So he had his timetable sorted out. Next comes the delirium. The delirium is something very simply explained is a temporary short circuit in the brain. And it comes when somebody is very ill, say they have got a chest infection, or somebody gets a stroke in the brain, or some people with Parkinson's, they tend to have those. And there's no treatment for delirium, except that whatever is causing that short circuit is stopped. So it's a easier thing to treat as compared to this. And the last one comes is dementia. Now, dementia, generally there are 2 types. There are many types, but what we see most frequently are 2 types. One is famous, Alzheimer's disease, sometimes known as senile dementia of Alzheimer's type, so quite a few names. And the other is called vascular. So I'll tackle the Alzheimer's one first. Alzheimer's dementia is where the process of aging has accelerated. So a person is trundling along the aging going at like normal driving speed, 40, 50 kilometers an hour. And suddenly due to some changes because of some genetic propensity or sometimes it's a gene happening aberrantly. We don't know for sure in every case what triggers it. And suddenly the aging process has reached 70 kilometers an hour. So the aging which should have happened over 15, 20 years time suddenly happens over 5 to 7 years. And it generally starts with little things like people forgetting the names of people they have known for a long time. Somebody comes into the house unexpected. And these people are struggling to say, what's the name? What's this person's name? It starts in a very subtle way. And generally, it is the family which notices it. The person himself does not. And then gradually, then more think calculation abilities, ability to count money, ability to navigate to the supplementary. These things generally tend to get lost as well over time. Then there is a vascular dementia, which I mentioned. It is generally seen after a stroke. Somebody had a stroke. It may be big or small, but it depends which part of the brain is affected. Now, the part of the brain which is affected, the brain cells have died. So whatever function they were doing, like ability to count money, ability to drive a car, these are lost. or diminished drastically. So these do not tend to get worse over time. They will remain there till the time a person has another stroke. And if somebody's blood pressure is not well controlled, their lipid profile or cholesterol is very high, these are the common risk factors. Not taking exercise, not doing exercise, regular physical exercise, again, increases the propensity for strokes. So if strokes happen over time, multiple strokes, then gradually there will be a diminution in other abilities as well. We don't tend to see much of this because once a stroke has happened, now most of the medications are there that they will prevent to a large extent from another stroke happening. And if the person has changed their lifestyle, then the possibility of another stroke happening goes down drastically. So those are the 3 Ds that we commonly see. Most often we also come across referrals from other physicians that this person is not what they seem to be a couple of years ago. And then we start probing, getting from the family how things have been going, since when they noticed that things were not so right as they were before. And often with support, with talking and needed medications, we tend to make a fairly good balance. Right. Any questions in the chat box?
So please do share your questions in the chat. We're talking about mental health of older adults. Is one question. The causes of dementia seem largely physiological. Does that mean it cannot be prevented?
Mrs. Chandrasekhar, if we are looking at, I said we poorly know what causes Alzheimer's. Why do some people go into accelerated aging while others do not? It tends to run in families, but not necessarily everyone will get it. There are few genes. The genes or the genetic makeup of the person can dictate to a large extent, but nobody can say for sure that this person has got this combination of genes, so they are definitely going to get dementia. It's a lot of, with most of the psychiatric illnesses, it's a close interaction between nature and nurture, as we say. Basically, nature means what we are born with, the genes, the genetic makeup of the person. And nurture is how we are living our lives. Sometimes the lines get crossed and things don't go too well. At other times, things are just running like railway tracks. Wonderful. I hope I have answered your question.
Please do keep putting your questions in the chat. I think we had got a question earlier about water. Sure. Okay, I'll take that question later. Would you like us to unmute you?
Let me have a look in the chat box.
Mr. Chidambra, would you like to put your question? You can unmute yourself. Would you be able? Please go ahead, sir.
There are two things I would like to ask. One is I find that there is a claim in Ayurvedic medicines that they will improve memory and rebuild the brain tissue, etc. Whether any integrated treatment system has been tried by any group of doctors, and if so, what results they have found. The second thing I would like to ask is whether any DNA studies have been done on the brain changes that happen, because you mentioned about genetic makeup, etc. I got this idea about asking you about this DNA studies in relationship to dementia or even Alzheimer's. Thank you.
Okay. So I'll take your second question first because it's easier to answer. There is no one particular gene which definitely causes dementia. The most studied gene is known as apolipoprotein E4. It comes in three forms, 1, 2, and 4. Now, people who have got more copies of the fourth variety are more likely to get dementia, Alzheimer's dementia. But they are more likely, not necessarily, they will definitely get it. So the whole thing is still up for confirmation. We cannot say for sure this person has got 4 copies of this 3 more type of E4, so he's definitely going to get dementia. Right. And I think your first question was that Ayurveda says that there are some medications or preparations with them which can regenerate the brain tissues. And has there been any integrated study? Am I right?
Yeah.
Okay.
And I have got some experience on that. I have used them and found some recovery of some memory compared to what I had lost a few years ago. That's why I give importance to this aspect.
Because Ayurveda is a very old literature base, and they have experimented. Unfortunately, allopathy and Ayurveda don't talk to each other very often. They are working with compounds because Ayurveda is based on experience of physicians of very old times, what they saw. But like in Ayurveda, they use the raw products, the leaves, the stem, the seeds. Modern medicine says there has to be 1 or 2 products in it, which on their own or together can produce the same changes in the brain or anywhere in the body. And so modern medicine has looked into it that let's get the active ingredient out of this. I'll tell you a story. For heart failure in 1850s or so, in England, they used a herb called foxglove. And the story goes that there was an old lady who lived on the outskirts of London, and people with dropsy, as it was called then, where there was swelling in hand and feet, would go there for treatment. When they looked at foxglove, they found the medicine digitalis, and that came out in early 1900s. And digitalis, well, till the end of 20th century, was a mainstay of treatment of heart failure or dropsy, as it was known. So that's how that was the difference between allopathy and Ayurveda is. But to answer your question very directly, no, not many studies have been done. In fact, I cannot recall anyone who has looked at an Ayurvedic compound and said, Ginkgo biloba, by the way, is a Chinese medicine, Chinese herbal medicine, which was claimed that it improved the memory. But when they put it through the studies, the rigorous ways modern medicine is developed, that was found to be no better than placebo or inert substance. So the way things work in modern medicine is one medication does not cure everybody for the same illness. Even people taking
Exactly.
hypertension. Sorry.
Exactly. If you would like to allow me to just to say a few words on that. One medicine will not cure any situation. There are two things I would like to say in this connection. First thing is, see, subjecting Ayurvedic medication or medicines for the blind studies, etc., which is followed in case of allopathic medicines is not a correct practice by itself. Ayurveda is a different science based on different criteria and different principles. So testing according to the allopathic principles and certifying them as not suitable is not correct thing. The second thing is they are showing results. In fact, in my case, I had this heart troubles, a lot of CAD and other heart troubles, which I got cured by homeopathy medicine. CAD is cleared, and by Ayurvedic medicine, not ashwagandha, some name is there. So memory is a little weak. There is another medicine. The name I am not getting immediately. By taking that, my other heart problems have become normal. I have become avoided. My heart became functioning normal. And I keep one dose, I take one dose of that medicine now and then to keep it in place. And it is working. Because the question is, it is working for me, it may work for somebody. It may not work for all the 100 people suffering from the same medicine, same type of disease, because their genetic structure or their other comorbidities or other changes in the body and in liver, etc., may differ. So if there is any failure, it can be taken as partly as a failure of the physician as well, not that of the incapacity of the particular medicine concerned. Even in allopathy, we don't use one medicine. We use different medicines at different stages. So I consider that as recommended by or propagated by Dr. Deepak Chopra, an integrated approach should be developed by the medical fraternity, the modern medical fraternity. Thank you for giving me this opportunity.
So I think I agree with you that Ayurveda is a different kind of science than allopathy. Their methods of testing a medication, how good it is, what are the side effects, are very different from the allopathy. I will not quote allopathy as a modern medicine. I'm just calling it allopathy. These are two very different branches and have different ways of processing things. And I like you said, in either of these specialties, not one medicine works for everyone. So if somebody wants to take the allopathic medicine along with the Ayurvedic medicine, that's perfectly fine. Sometimes it may lead to some problems, but in very rare cases. But otherwise, it's perfectly okay to take homeopathy treatment along with the allopathy. It's fine to take Ayurveda or Unani medicine if the person has the faith in them.
I would like to counter here. There is no question of faith, sir. Professor, there is no question of faith because the medicines work. The faith may be a little extra push for the medicine, but definitely a substance given, infused into the body of a patient will definitely have its own effect. If there is no faith, it may take a longer time. But if somebody resists, it may not work at all. I agree to that extent, but the entire thing doesn't depend upon faith alone. I hope I have made it a little bit clear.
So we can talk about this for next 2 hours: faith, belief, resistance, everything. But I think we both are saying the same thing. One has to believe in the medication for it to be effective.
Wonderful. I mean, I think we have a couple of more questions and people waiting to ask. May I request Aisha to ask your question?
Yeah, thank you. So, doctor, we are having this session, both doctors, on geriatrics and, people who, there's atrophy of the brain when you age. But what about in younger people? I'm dealing with someone in their mid-60s who has been...
seem to have lost you.
You can't hear me?
Yeah, can you please repeat that?
So I get this thing about, the brain atrophying as you grow older. But what happens when you're diagnosed with MCI when you're in your mid-60s? The family finds it very difficult, and there is really no support structures always for older people. The dynamics, I think, changes for someone when they're in the mid-60s. I mean, my question is, does the dynamics change for someone who's in the mid-60s? And how do we get help for someone who is physically fine, but let me put it very bluntly, mentally debilitated? As you grow older, it's both. But here's someone who's physically fine. And it's a very stressful situation.
It is. It is. It's more stressful for the family than it is for the person concerned. But what I think the first part of your question was, what if somebody gets a diagnosis of MCI? That's right.
Right. Right.
MCI meaning mild cognitive impairment.
Cognitive impairment, yes.
Meaning that people think they have got forgetfulness, they forget things, but on objectively testing the memory and intellect, there is no deficit. That's my understanding of mild cognitive impairment.
Then I think the diagnosis is not correct in this instance, because I think there are moments of lucidity, there are moments of, on arithmetic, it's fine, but there's forgetfulness. A lot of what you said on the Alzheimer's thing falls in here. I was listening to, forgetting names, can't count money, no touch with reality. I mean, that's the 60s situation we're dealing with someone in their 60s. So whenever I go looking for care, it's always a home which is 80 plus. So how do we manage this?
You mean manage the
medical part? The medical part. Obviously, the brain is not so atrophied as an 80-year-old. There is chances of arresting it, maybe not reversing. We're struggling.
It depends on what's happening actually, what's going on in the brain. Diagnosis.
So can I do a private consultancy with you?
Sorry?
Can I do a private consultancy with you? Because doctor said this is going on YouTube and I'm really concerned about making this public.
Sure, yeah. I think we can, we should ask probably more generic questions. We'd be happy to connect you.
Sorry. I'm sorry. I'm sorry.
For more, as you're comfortable. But just to mention, I'm sorry, sir, if I may just kind of add that this is actually something that a lot of people who reach out to Samvedna come with. Also because, there's a bit of a, we do also feel that a lot of people think Alzheimer's or dementia is something that happens only in very old age. It's sometimes kind of confused as being a normal part of aging. But it can also occur at younger ages. So I completely understand what you're saying, ma'am. And I think you mentioned about homes, which are largely with people who are in their 80s. I think at Samvedna, one of the models that we follow is to support for home-based care. So we'd be happy to connect with you later. And
all right. Okay. Thanks.
Connect you.
Thanks. I don't want to take up too much time. Thank you.
So, no worries. But sir, please go ahead if there's something that you would wish to add.
There was another question in the chat box.
Yes,
just now.
we can okay, so there is one question that in the US dementia has proactively entered epidemic stage. Meanwhile, the same hasn't been seen in India. Are there any specific protective factors that are culturally specific to India?
Oh, I was hoping nobody would ask this question. But right, in 70s, from 70s onwards, it was thought that the incidence of dementia was on the rise consistently in Europe and America and Australia. But in India, doctors were not seeing cases of dementia. So everybody thought there's something in our diet, in our lifestyle, which is preventing dementia from happening. And things narrowed down to curcumin. हल्दी जो खाने में यूज होती है, इंडियन खाने में बहुत ज्यादा यूज होती है, उस पे आ गई कि हल्दी इज प्रोटेक्टिव. But later on, it was shown not to be when put through the scientific rigor. Then in 90s, the University of Philadelphia in Ballabgarh area, which is in Gurugram, conducted a very large study. They, with the Institute of Aging, they studied about 7,000 people. They assessed them very rigorously. They did the blood tests and everything. And they found that there's a very low incidence of dementia in that population. So the publication from this came out in 1999, and which kind of conformed with what was there for last 25, 30 years about the feeling. But then more people started becoming in geriatric psychiatry and dementia, and more studies were conducted in the population. So east, west, north, south, rural, urban, educated, uneducated, or farmer versus, there's no clear consensus. Everybody is now in India is saying that there's going to be an epidemic. By 2050, we'll have so many cases that will be staggering under it. But these seem to be limited to pockets, different pockets in the country, if at all. So I am personally, this is my personal opinion. So I am very much against a diagnosis of dementia, in the sense that when you see a person for the first time in the clinic, it's very difficult to give a diagnosis of dementia. I need at least 2 or 3 months to see the person, how they are going, put them through psychological tests, some blood tests and things. Because somebody who's very much depressed can also have problems with memory. And if looking at it in a very cursory way, one say, oh, this person has dementia. But it's a diagnosis not to be jumped on, because what we are saying when somebody has got dementia is saying that, look, this person is never going to get better. This person's physical and mental needs are going to be increasing with every passing day or passing week. There's going to be a lot of burden on the family members, and this person's lifespan is limited. So it's not a diagnosis to be given in a hurry. But to answer the question that there seems to be a proactive epidemic in the West about it, I don't think the literature in India supports that there's ever going to be an epidemic, as if one critically looks at the literature. So the jury is still out. So we are still saying that what was said in 1970s, either our cultural makeup or our diet or our lifestyle, or possibly all these and a few other factors, are protecting us from this proactive epidemic. And let's be thankful about it, shall we?
So I think that leads very well into another question that we have in the chat about active involvement of older adults in hobbies or arithmetical puzzles and whether these prevent the onset of memory-related disorders like dementia. What are some of the other things that older adults can do to prevent the onset of dementia?
My favorite is जिस चीज को इस्तेमाल नहीं किया जाता उसमें जंग लग जाती है. My favorite line. The more we use our bodies, including the brain, the more healthy it will be. There's nothing to stop a person who's 62 or even 72 years old going to the gym. He may not be able to do as much as the younger people over there, but that's taken care of 2 hours of the time, if nothing else. 30 minutes of going to the gym, 1 hour working out, another 30 minutes coming back. There is some physical exercise. In fact, I think that some for older adults in their gym, like this time for ladies, there should be time for older adults as well, or senior citizens. That may be a good marketing strategy. So does that answer your question? Yes, doing puzzles, working out in a gym, basically using the mind or the brain in any way is going to retard or slow down the aging process.
And I think you
I could give you an example, but that may not be very politically correct. Look at our Prime Minister, right? He's still using his mind actively, leading the country. Physically healthy, he does yoga every morning. So the more one uses the body and the mind, the less the effects of aging. So I always say, there's a very young looking 70-year-old person and there's a very old looking 60-year-old person.
So it's an important combination of good nutrition, active exercise, using your mind. You mentioned, sir, earlier, learning something new, keeping yourself active.
Yes, something even as simple as making a telephone call and talking to an old friend for 15 minutes a day. That's there because those 15 minutes, the mind is active. It's digging up the old memories. One is thinking. So something even as simple as that. That's why what I see that people who are living in a joint family setup are less affected by memory problems and things. Because there's a lot happening around the house. The grandchildren are running around trying to tear the house apart. The parents have a competition who can shout the loudest at the children. Right? So there's a lot of there's a lot of external impulses coming into the brain, which is keeping one happy,
So the bottom
yes,
line.
whatever you can do.
Wonderful. I think we have, please do type your questions into the chat or let us know if you'd like to ask your question to Sir. We have another question that is, it's often a struggle to convince older family members to take care of themselves or address a diagnosis. How do we approach this subject?
It depends on what the problem is, who the person is, and sometimes what the diagnosis is. Because it's well known that as the age goes up, whatever our personality is, some parts become more strong, others tend to be lost along the way. Some people become more stubborn, others are more compliant. But if that's a person without any problem, without any psychiatric problem. But if it is a psychiatric problem, that may further make matters difficult. So if somebody is having depression, for example, and they are feeling lazy all the time, tired all the time. They don't really want to get out of the bed or have a bath every day. They let the hair grow, do not shave, which are all symptoms of depression, which is a kind of a neglect of one's own body. Then the approach will be to treat the depression, be it by counseling, psychotherapy, medications, or a combination of these. And then things will go back to the way they were. But if it's like personality traits, that's some people has become more again, not a very good example, but somebody who was very stingy with money, and suddenly this trait has become so prominent that they do not allow any extra lights to be switched on in the house. Then it's more difficult to treat. Well, you can't treat something which is not caused by an illness. So it's more difficult to handle that. I think if it is only this personality issues, then distraction should work. Probably the person has got that they have got too much time on their hands, not enough to occupy their keep their brains ticking. So they stick to the little things, which suddenly become very big. Something mountain out of a molehill, a molehill out of a mountain. I'm not sure. Yeah, making a mountain out of a molehill.
And I think also, I mean, that leads me to a question that a lot of people ask is, what is the role of family members? How can they help support an older adult with mental health problems? We have a comment in the chat about many times a person is not willing to come forward for treatment of depression. And I think, right now with the pandemic, we're seeing a lot of, particularly an increase in depression and anxiety as well. So if a person's not willing to come forward, what can family members do to help?
I can tell you what they should not do. Do not be punitive with them. Do not be harsh with them. Because somebody who's 75 years old has developed a depression and they think that they have done all they had to do in their lives and now it's time to pass away quietly. Very large part of this thinking may be colored by depression because they were well and healthy a year before the pandemic started. It's more a matter of coaxing them, persuading them gently. And a good geriatric psychiatrist is one who's not going to interrogate the patient. It's more like having a chat with them. Right? I give you an example of that. A lawyer who has done 6 MA, and I'm sure by this time he must be on the 9th. Those were my exact conversation we had. Why does your family think you need a mental checkup? So I think the quality of a geriatric psychiatrist or a geriatric counselor or psychologist is to be conversational and get the information there, which I think applies to every branch, but more to geriatric psychiatry. And one thing which I often face is that I'm talking to people who are 20 years older than me, or even 30 years older. So it's a balance of power there. Age is always respected. So the doctor, the profession is respected. So where does the balance of power lies? Right in the middle of the table, mutual respect for both. Right? So it's not easy. Very, sometimes it can be very difficult for somebody with depression to persuade them to go and see a doctor or definitely a psychiatrist. So it's
There's a
more
lot of
like
stigma also.
a stigma or ignorance. I still haven't made up my mind which one is more. Because depression is an illness which is very difficult to recognize by oneself.
Hmm.
If I don't feel like getting up in the morning one day or for a week, I just think I'm too tired. I've been working too hard. right? Or because rationalizing it, why do I need to get up at 7 a.m.? The sun is still going to be there. Those young adults are still going to be rushing off to the office. I can afford to get up at 9. I'm the lucky one, right? So it's more like trying to rationalize. People don't realize that there's something wrong, and it's treatable. The sooner one sees a professional, the better it is. But like I said, it's difficult. And sometimes, thanks to the internet, family members keep telling the person that you are depressed, which may not necessarily be true. So what I said at the beginning, the first thing is not to be confrontational or punitive. Work with the person.
So I think we have a last couple of questions. Please put any more questions that you have into the chat. We have one person who wishes to know that in an Indian setting, geriatric problems, especially dementia, is addressed by both the Department of Psychiatry and Neurology, I guess. Being a caretaker, how can I decide which department is concrete and appropriate to approach for an initial assessment?
Go for both. Get the best. In the end, the person is an individual. That person may get along well with the neurology team, or the person may get along well collaboratively with the psychiatry team. In the end, all the professionals, all the doctors, whichever specialty, we offer treatment. It is up to the individual or their family to accept it or not to accept it. So it's the same illness, it's the same person, the approach may be different, but it doesn't matter.
And I think the bottom line is really to get help, to take that opinion.
The bottom line is to get help on a basis which is needs based, i.e. that I need help with this. This is the major problem. So let's try to address this.
So we have a last couple of questions asking about whether, when we talk of mental health policy, is this, how does this reflect for older adults?
What is the mental health policy for older
adults in India?
There's no as such a mental health policy. It's in the process of being formulated. So there is a national service framework for the older adults, but mental health is not specifically included in it. And if somebody wants, I can have some people talk on the different legislations which are currently there as applies to older adults only. But that will be a whole session for another day. And it's not going to be that much interactive. It's going to be educating about what the legislations are, rather than posing individual questions.
I think so. We're going to take you up on that, because we do get a lot of questions asking about legislation specifically related to older adults. And I think on that note, if there are no more questions from...
There was something about affordability.
Yes, there's one more question about views on affordability and accessibility of mental health care for older adults.
I think older adults are no different from younger adults in this respect. It's across the board. At least that's one thing in which there's no inequality. But yes, there is accessibility, not accessibility and affordability. That's not the issue. But I think that the psychiatrists and physicians are not that much tuned into dealing with an older person right now. Because one thing which I think I have not mentioned as yet, that with older people, one has to speak loudly, one has to speak slowly, and always cross-check the answer which is coming through. Right. So the communication style changes. It's not like this is a problem, this is a medication, you take one 3 times a day, other 2 times a day, and third one 4 times a day. No, it doesn't work like that. You have to go through each of them, how to take it, when to take it. Keep the prescription simple. So yes, there's a lot more training required in having physicians deal with older adults, taking into account that their brains might not work at a very as quickly as somebody else. They may have difficulties in hearing, and they may have difficulties in seeing things as well. So all these things have to be taken into account in a clinic.
And I think those are really important pointers if there are any physicians who are listening in. I think for them to keep in mind. I think this is something that I often see also with the people that we interact with that particularly older adults may sometimes feel hesitant to ask questions to the physician or the professional that they're working with. And I think I always tell people that you must ask questions. If you are not understanding what the doctor has told you, you absolutely must cross check. So I think
Yeah, definitely. I think my very cynical opinion on this is that our older adults belong to a different kind of generation with a different kind of thinking. Asking a question means defying the authority. That's not the case now. They're not like the young teenagers now. I won't do it. Why should I do it? So that's I think there's a century of difference in thinking.
So I think we have one last question that we can take. Not only older adults, but younger generation seems to struggle with emotional issues. What kind of lifestyle changes can be made to improve general well-being?
I think we have already covered this. The prescription here is, the broad prescription is, keep the mind and body both active. Physical activity, good nutrition, fixed bedtime, daily activities, even socialization as a prescription. To be done thrice a day, I'll make a phone call. If not, go over to the neighbors to borrow a cup of sugar. So the idea is keep both of them active. And that how one takes it, it depends on the individual. So there's again no set prescription for everyone. I say, yeah, you should go to the gym every day, if not 4 times a day. But a gym may not be accessible all the while for everyone. It may be too far off. They may need somebody to go. But walking in the housing estate may equally do the job. Right. So the bottom line is activity, physical and mental both.
So I think that's on that note, sir. I think we want to thank you for your very valuable insights. I think that's a prescription that younger, older adults. I think it's something we all need to follow for better well-being. Physical activity, mental activity, as you mentioned, and spiritual counseling. So spirituality, again, as one of our listeners has mentioned, all of these are really important aspects. Any parting thoughts, sir?
I must say I thoroughly enjoyed today. I didn't think after a long day's work, usual office, hospital, and meetings and everything, I'll feel so much good after the meeting. but I am surprisingly. Thank you very much.
Thank you. And I hope that everyone who's listening in has also enjoyed the session. At Samvedna, we keep holding regular sessions to discuss various issues about mental health and um, care, healthy aging. So do join us for those future sessions. I think this is relevant. I think age is just a number at the end of the day. But as Doctor was mentioning, mental health, physical health, this is important irrespective of age. So do join us for our future sessions. As I mentioned earlier, this will be available on YouTube. So do share this with anyone who's not been able to join. And I really want to thank Dr. Srivastava for sharing his valuable inputs. We've covered such a wide variety of areas through this discussion, and I think everyone who's listening in has picked up on a couple of pointers at least to take home and start practicing things for better mental well-being. So thank you very much, sir, and thank you for your time. As you mentioned, I know you have a very hectic schedule, sir. So thank you so much for being with us today.
Thank you. It was a pleasure. Bye for now, everyone.
Thank you so much, sir. Thank you.